My name is Dr. Sanderson. I'm one of the GI faculty. I'm a 2001 graduate of the College of Medicine. And I wish that when I was a medical student, we had the opportunity to have a program like what you're going to see today. I chose gastroenterology almost through happenstance. I was really impressed with surgeons like Dr. LaFall and Dr. Mattori, and I was thinking about going into surgery. And I was at an NMA conference one year, and I bumped into a GI doc who said, why don't you check out GI as a specialty? It's a great mix of doing procedures and seeing patients in the clinic. And it turned out to be probably the best thing that I could have chosen. Very, very happy with the specialty. It is providing me the opportunity to do a lot of things at a relatively early part of my career. One of the things that I wanted to do was be involved with the ASGE, which in conjunction with the AGA is putting on the program today. So these are two large GI societies which represent practicing gastroenterologists and academicians who really care about the complexity of the people who are their members. I was part of the ASGE Diversity Committee, and we're lucky to have today Dr. Tanya Adams, who is the chair of the Diversity Committee with us. And Dr. Adams will give a few remarks. I also would be remiss if I didn't acknowledge someone who isn't here, who would have liked to have been here, which is Dr. Maria Abro from the AGA, who, working synergistically with Dr. Adams, wanted to bring this program to Howard, to a place where there are many medical students who could benefit. And this is actually the first program, and we're hoping to have many more. To begin the program, we have one of our Howard GI fellows, Dr. Wyndham, who is going to come and give us a presentation to give you kind of an overview of what a gastroenterologist does. Dr. Wyndham came to us from Tennessee. He is an excellent fellow, but he is also an excellent person. And I think all of our fellows are very good. One of the reasons we chose Dr. Wyndham to come here to Howard was because, through his life experiences, he's shown a lot of perseverance and a lot of excellence. And we always want people who are excellent to be here at Howard, but also we want to keep doors open so that we have people who can participate in subspecialties such as GI. We want you to know that if you're excellent, no matter how competitive a specialty is, whether it be cardiology or GI or any of the surgical subspecialties, that there will be a place for you. So without any further ado, Dr. Wyndham.
Good evening, everyone. My name is Dr. Michael Wyndham. I'm actually a first-year GI fellow. She came in from the University of Tennessee, where I did my residency training, and I'm excited to be here. GI has been more than what I've expected it to be. I'm learning something new every day, and I'm glad that I was given the opportunity to be a part of this field. Without further ado, I want to go into the presentation, just giving you a brief overview of what a gastroenterologist does. So some of the things I want to begin talking about is one, what is gastroenterology? Two, how does the digestive system work? Three, what is involved in GI training? And how can the AGA and ASGE societies help you? So I like sometimes audience participation. So can anyone tell me what gastroenterology is? Anybody? It's not a hard question. Okay. So gastroenterology is basically a branch of internal medicine that deals with the digestive system and its disorders. Okay. And so what is a gastroenterologist? A gastroenterologist, by virtue of the fact of being in gastroenterology, deals with the disorders, both the management and the treatment of disorders of the digestive system. So it's a subspecialty of internal medicine It basically studies the diagnosis and treatment of these disorders. So you start off with internal medicine, which is what I did at University of Tennessee. And then once you finish your training in your basically general medicine, internal medicine, you dive into the subspecialty of GI, where you learn how to manage these specific disorders. So the first thing I want to talk about in terms of the digestive system and how it works is let's go over the different components of the digestive system. So we have the upper GI tract, which consists of the mouth, the esophagus, and the stomach. You have the lower GI tract, which consists of the small intestine and the large intestine. And then you have your accessory organs like the biliary tract, including the liver and the pancreas. Okay? And all of these organs work together to function in the digestive system. Okay, so now we talked about the major components of the system. Let's talk about some of the processes involved with these particular organs. So you have, the first is assimilation. So nutrients are absorbed and are utilized by the body to carry out homeostasis, as well as to be utilized for other processes throughout the body. Digestion begins in the mouth with the breakdown of food. And after digestion occurs, you get absorption. And nutrients are mainly absorbed in the small intestine. So you have your macronutrients, which is your proteins, your fat, and your carbohydrates. And then your micronutrients, which are your vitamins and your minerals, which are all essential for normal growth and physiological function. Water is absorbed in the small intestine and the large intestine, and where everything is eventually absorbed into the portal vein, which goes to the liver. You also have not only absorption but excretion, so waste products are eliminated via the large intestine. So let's talk a little bit more about absorption. Nutrient absorption is site-specific. So throughout the digestive system, there's certain areas in the GI tract where certain vitamins and minerals and macronutrients are absorbed. And when you have areas of abnormality that prevent absorption, you get disease processes, specific disease processes. So, so the potential deficiencies depend on not only disease location, but also surgically induced changes in the anatomy. So if you look at the diagram on the right, you have acid produced in the stomach that aids in digestion, as well as breakdown of the macronutrients. And you have absorption of those nutrients in the small intestine, preferably the jejunum, which is a part of the small intestine. So your fat-soluble vitamins, your iron, your zinc, calcium, water-soluble vitamins are absorbed in the small intestine. Folate, as you can notice from the diagram, is only absorbed in the jejunum. And I'm sure a lot of you all have learned about B12 and B12 deficiency, and B12 is only absorbed in the ileum. So any abnormalities in the ileum can lead to a deficiency of B12. Carbohydrate digestion begins in the mouth via salivary amylase. You have protein digestion in the stomach, and you have fat digestion, which occurs in the small bowel. So the digestive system is regulated by two parts of the nervous system. There's the extrinsic nervous system and the intrinsic nervous system. The extrinsic nervous system comes from the unconscious part of the brain and the spinal cord. So via the parasympathetic nerves as well as the sympathetic nerves, they work in conjunction to the parasympathetic, activates the GI tract, increases motility, and increases secretion, and the sympathetic nervous system does the opposite. It slows down motility and it decreases secretion. The intrinsic nervous system, I have another slide that talks about this a little bit more in detail. It is considered the second brain of the GI tract, and it has its own intrinsic nervous system. So the extrinsic nervous system is mainly mediated by the vagus nerve, and it works via neurotransmitters, specifically acetylcholine, which stimulates peristalsis and secretion. The adrenaline is also another nerve transmitter that is activated via the sympathetic nervous system, and it relaxes the gastric and intestinal muscle and also decreases blood flow. So the intrinsic nervous system acts like a local computer. It initiates responses that are reflexively stimulated by the intrinsic nervous system. It coordinates and controls peristalsis. And the reason why it kind of acts like a local computer, because if it's normally regulated by the extrinsic nervous system, but if the extrinsic nervous system is not working properly, or if there's an issue, it still can perform its natural functions independent of the extrinsic nervous system. So how does the digestive system work? You also have the liver and the pancreas, which we mentioned earlier, are accessory digestive organs. So they produce digestive juices that flow throughout the small tubules or ducts into the upper small intestine. And they have important vital functions and control the metabolic functions, help with the digestion of fats, as well as deal with glucose metabolism. So what are some of the common disorders that we see as gastroenterologists? So some of the more common upper GI tract conditions are gastroesophageal reflux disease, or GERD. I'm sure a lot of you all have heard of reflux disease. It's a condition in which the stomach acid and bile are refluxed back from the stomach into the esophagus, and can cause discomfort, heartburn, indigestion. You probably see a lot of medicines like the proton pump inhibitors, or Nexium, purple pill. I think it was one of the most prescribed acid suppressive medicines, particularly for reflux disease. Peptic ulcer disease is another disease we see commonly. It's associated with ulcerations in both the stomach and the small intestine, and it's mainly caused by two factors, non-steroidal medications, as well as an infection called Helicobacter pylori. And we usually see this in the hospital in patients that have bleeding from ulcers. Celiac disease is another common condition. It's an immune reaction to gluten, which is a protein in wheat, that leads to destruction of the villi, so it causes a malabsorption disorder, and can cause diarrhea, as well as malabsorption of fats as well. So the lower GI tract, common disorders we see. Irritable bowel syndrome is actually very prevalent. I think it has a prevalence of about 10%. And it leads to a lot of not only just office visits for gastroenterologists, but primary care in general. It's a common disorder that leads to crampy pain, bloating, gassiness, and changes in bowel habits. So these patients can have constipation, they can have diarrhea. Inflammatory bowel disease is another disease entity that don't quite know the exact underlying cause of it, but it's associated with two distinct manifestations, Crohn's disease and ulcerative colitis. And these are chronic inflammatory conditions of the intestines, and they affect adolescents as well as adults. So the gallbladder and the pancreas disorders include gallstones and pancreatitis. Some patients have gallstones and have no symptoms at all. Some patients do have symptoms related to their gallstones, and they can present with abdominal pain, nausea, and vomiting. And typically for these gallstones, we usually remove the gallbladder. Pancreatitis is another disease entity that's actually related to gallstone. It's an inflammatory process of the pancreas that can be either acute or chronic. And the most common causes in the United States are alcohol and gallstones. These are other disease entities that we see regularly as gastroenterologists. Liver disease, so viral hepatitis is something we commonly see as well. and it's usually due to a number of different viruses: hepatitis A, hepatitis B, C, D, and E. Hepatitis A and E are usually more acute, and we see also chronic hepatitis in patients with hepatitis B virus as well as hepatitis C. Autoimmune hepatitis is an immune reaction of that's directed towards the hepatocytes in the liver, and this leads to also acute and chronic hepatitis. Cirrhosis is generally just a scarring of the liver, and this can be due to a lot of different etiologies, including chronic hepatitis B and chronic hepatitis C. These patients are increased risk to develop liver cancer and also have a need for liver transplant if they develop decompensated cirrhosis. There are 5 million people in the United States that are affected with hepatitis C, which frequently leads to chronic hepatitis, cirrhosis, and also liver cancer. Obesity is another common disorder that we see as gastroenterologists. And obesity is actually a lot of research undergoing obesity and what causes obesity. But some of the major players include gut hormones may play a role in the regulation of food intake and energy metabolism. There's incretin regulates glucose homeostasis and also possibly weight gain. There's also association with the greater risk of obesity-related cancers, including colorectal cancer, which is something gastroenterologists manage commonly, and it's associated with overall increase in mortality. So if you're interested in nutrition, there's also a niche for you in gastroenterology. So this is a graph showing the obesity trends in the United States from 1990 into 2009. And one of the things you can notice from these graphs is that the percentage of people with obesity has increased throughout the United States from 1990 into 2009. And most commonly, the most densely populated area with increased rates of obesity are actually in the Midwest and the South. This is a graph just essentially showing the increase in mortality associated with BMI. So as your BMI increases, you move from a low-risk category to a high-risk category as your BMI goes over 34, and it's associated with an increase in mortality. One of the main things, one of the main reasons that interested me in gastroenterology was colon cancer. Why colon cancer? It's actually the second leading cause of cancer deaths in the United States. And it's also the third most common cancer in men and women. And if you look at the data from 2007, the number of new diagnoses were 142,672. And if you look at the breakdown between men and women, men are more affected than women are. And if you look at the number of deaths associated with colorectal cancer, the breakdown, men are more common to die from this disorder than women are, according to 2007 data. But still, I mean, why colon cancer? Particularly, it's important because we see a lot of colon cancer, both incidence and increased mortality, in people of color. So looking at this graph here, you see that it's broken down to male and female, but if you look at the ethnicity, blacks are more higher, both for men and for females, in the incidence of developing colon cancer. Incidences mean the number of new cases that we see in a given year for a particular disease entity. And if you look at the next graph, which shows colorectal cancer death rates in the United States, blacks are among the highest group that are associated with increased mortality compared with the other races. So this is just a diagram showing the progression of colon polyp. Usually we describe these to our patients as possible precancerous lesions. So you have a small sessile polyp or flat polyp that progresses to a pedunculated polyp, and that just means it has a stalk and is increased risk for development of cancer to development of full-blown adenocarcinoma or colon cancer. And these are, at the bottom, these are just pictures endoscopically during a colonoscopy that shows the progression of the histology from a sessile polyp to adenocarcinoma. And it usually takes about 10 to 15 years for this to develop. So colon cancer testing is effective. And one of the things that I like about it is that we can catch cancer early, and we can do something about it, which is important. So this just shows a polyp on the left, the pedunculated polyp, that is caught early if it's precancerous. If we remove it, we're able to prevent the development of cancer, or which is the picture on the right, which is the development of adenocarcinoma. So colonoscopy, what is a colonoscopy? So typically a colonoscopy takes anywhere from 30 to 45 minutes to perform, depending upon the patient. Typically what we do is we give them medicine, a laxative to help clean them out. And that way we're able to, number one, get a better visualization of the colon, because obviously if we go in and we look in their stool, then we can't obviously see the whole colon, and we can't see polyps, and we do you a disservice by not being able to catch the polyps early. So we give you the laxative to clean you out, and then we take the patient, comes in for the colonoscopy. We give them medicine to put them in a light sleep and control any discomfort that they may have with the actual exam. We turn them on their left side, and we insert the colonoscope into the rectum, and we advance it all the way to the right side of the colon. So this is just a picture showing the colonoscope going through the rectum through the sigmoid colon, up through the descending colon, and actually it's all the way up to the splenic flexure, but we typically go further than that, all the way to the right side of the colon to look for colon cancer. So this is just a schematic showing that, and this is showing the tip of the scope. So there's an instrument channel which we put our tools through if we have to take a biopsy, which is just taking a piece of the tissue, or doing something called a polypectomy where we remove the polyps. The instrument channel is used for that, and then we have a light source at the end of the colonoscope, as well as the video camera lens, which we're able to see through. Polypectomy, and this simply means removing a polyp. So this here shows removal of a polyp via snare polypectomy. So we take a catheter, we place it through the instrument channel in the scope. We open up the wire over the top of the polyp. We place the catheter at the base of the polyp, and then we tighten the snare around the polyp, as you see at the bottom of the diagram. And then we use electrocautery, and we cut and burn through the polyp to remove it. So virtual colonoscopy, this is another screening modality that's sometimes used in patients that refuse a colonoscopy or don't want to have a colonoscopy. You still have to be prepped. You still have to take a laxative to perform it. And if there's a polyp that's seen, you still have to have a colonoscopy. But it's just an alternative method to screen for colon cancer. So the endoscope. So just talked a little bit about colonoscopy. The endoscope is another endoscopic instrument that we use to examine the upper GI tract. So this is just a picture showing the endoscope. You have here on the left the control mechanisms of the scope. So the large wheel basically helps to deflect the tip of the scope up and down. The smaller wheel furthest on the outside helps deflect the tip of the scope left and right. And then the buttons, the top button on the colonoscope allows us to suction fluid and debris from the colon. And the bottom button helps us insufflate air, so we put air into the colon to distend it, so we can are able to get a good look throughout the colon. And then if you hold the button for the air down. It helps clear your lens and allows you better visualization within the colon. So upper endoscopy, or esophagogastroduodenoscopy, or sometimes you may hear us refer to it as an EGD, is endoscopic procedure performed in patients who may have unexplained abdominal pain, unexplained nausea and vomiting. If we're suspicious for peptic ulcer disease, we perform upper endoscopy to take a look mainly at the esophagus, the stomach, and the first part of the small intestine. So we use it for diagnostic as well as therapeutic purposes. So in these pictures, you actually see peptic ulcer disease. So on the picture on the right, you see an ulceration within the stomach. And on the left, you see, actually this is a picture of a bleeding visible vessel that I'll show you a video of later, and how we manage it. But we do biopsy. Dilation we do in patients that may have difficulty swallowing. We're able to dilate the esophagus to help with the passage of food. Sometimes we place stents if needed, if there's an obstruction, and sometimes we use stents. So capsule endoscopy, what's capsule endoscopy? It's a capsule that you swallow. We use it in patients with, if we're suspecting Crohn's disease, if we're suspecting a bleed in the small intestine. A colonoscopy and the upper endoscopy are not able to visualize the small intestine, so we use the capsule endoscopy. It has a camera on the inside. The patient swallows it, and they're hooked up to some electrodes, kind of like an EKG machine, on the actual body, and the capsule takes pictures all the way through the small intestine, and that way gives us an idea of any pathology that the scope wasn't able to see. So this is just a schematic of or a diagram of the capsule itself. So here's a video actually of an upper endoscopy within the stomach. Actually, if you see at the bottom of the screen, there's a clean base ulcer there. And this is the more distal portion of the stomach. The small opening that you see is the pylorus, which is the opening in the beginning of the first part of the small intestine. So this is what you would typically, or you would see, not necessarily the ulcer, but you would see doing an upper endoscopy. This here is a picture of beginning of sclerotherapy for a bleeding vessel within the stomach. So this is the gastric antrum. So here you see the scope, and you see a needle coming out of the scope. They're actually injecting around the vessel. Typically, we use epinephrine, which causes constriction of the vessel to stop the bleeding. And then this is after sclerotherapy is done. You see bleeding is stopped. Here is another modality that we use to treat bleeding. This is called clipping. So we place a clip actually around the edges, the edges of the bleeding vessel or a bleeding ulcer. And see, this is a picture after the clip has been deployed, that the bleeding is stopped. This is a picture of a capsule endoscopy, so kind of what I just went over. So this is showing an NSAID-induced ulcer within the small intestine that otherwise wouldn't have been able to be viewed by the upper endoscopy. So this here's a picture showing polyps doing a colonoscopy, different types of polyps. So you see some flat polyps, and then you see first picture was a pedunculated polyp. And this here is showing snare polypectomy, so kind of what I talked about a little earlier. You see the wires being deployed over the top of the polyp and secured at the base, and then it's lifted off of the mucosa, and it's electrocautery is used to burn the polyp, and then it's secured and removed from the colon. Okay. Those are basically, in a nutshell, kind of what we do. There are a lot of different disorders that we treat. At this time, I'd like to bring up Dr. Tanya Adams, who is the chair of the diversity program.
Thank you, Dr. Wyndham. And on behalf of the AGA and the ASGE, I would just really like to take a moment to thank Dr. Sanderson for making this happen. This is our first Investing in the Future program, and we're really excited about having this here. And I stand before you representing two organizations, the AGA and the ASGE. My counterpart, as Dr. Sanderson mentioned, is Dr. Maria Brew, who cannot be here. She's at the University of Miami, but she's certainly here in spirit. So again, thank you for having us. I would have to quickly corroborate a story that Dr. Sanderson mentioned in terms of, why GI? I remember when I was a resident, my first year residency, I thought I was going to be a cardiologist. And there was a faculty member at Johns Hopkins where I was doing residency who was a gastroenterologist, and I had spoken to her. And she said, you should consider doing a rotation in GI. You may like it. And I had never before considered GI, although I found it pretty interesting. And I did the rotation, was very interested in it, and I actually did a second rotation. The rest is history. Here I am a gastroenterologist now for 10 years. So I think that gastroenterology has a lot to offer. I'm going to mention a lot of things about the field, some things that may overlap a little bit with Dr. Wyndham, but some things that are a little bit different at the same time. And I'm going to have to ask Dr. Wyndham, how do I go forward? There we go. All right. So I'm going to start off talking a little bit about, you've heard a little bit about gastroenterology and what gastroenterology is all about, but it's basically a diverse subspecialty field of internal medicine that includes both acute and chronic care of adult patients with disorders of the gastrointestinal tract. It was back in the late 1800s that sort of the founder of gastroenterology, Dr. Ismar Boas, who was a German physician, actually sort of pioneered this whole idea that gastroenterology was a separate entity from internal medicine, still under the same umbrella, but still an entity that was important in and of itself and should be separate. It wasn't until the 1940s, however, that the first American Board of Internal Medicine certification was actually administered for gastroenterology in the United States. And since that time, we've seen a steady growth in interest in gastroenterology, as well as the number of certifications per year, now averaging about 4,000 per year since the 1980s. Currently, we have greater than 14,000 practicing gastroenterologists in the United States, and in spite of that, there's still some projections that there will be a shortage of gastroenterologists in the future. So there's maybe something for you, and hopefully tonight we can convince you that gastroenterology is an interesting field to consider. So of that 14,000, when you look at the demographics, this is information that's drawn from the ASGE database. When you look at the demographics in terms of background, what we find is a couple of things I'll point out to you. Essentially, the blue line bar actually represents practicing GIs, the red GI fellows. And essentially in terms of practicing GIs, which again kind of represents on average the baby boomers, so those that were born between 1946 and 1964, the highest numbers fall into what's self-described categories of Caucasian and Native American Indians. Which you'll also note is, again, for practicing GIs, again, the blue bars, African Americans and Hispanics make up sort of the lower tier numbers. When you compare that with current day GI fellows, however, the numbers change a little bit, and we're seeing still predominantly represented by Caucasians, but you're seeing more Asian Americans as well as other, and I'll come back to this other category. What I think this shows is that when you compare practicing GIs, who again sort of represent a different genre of medicine and gastroenterology, with more current day gastroenterology trainees, there is a trend where we're seeing a little bit more diversity, and I think that's going to certainly reflect in the future of practicing GIs. In terms of variables that would affect this number, you see here that there's a lot of people, particularly GI fellows, who fall into the other category. And these, again, were self-described in a survey. And so it's not clear if some of the people in other were people who could have actually fallen into these other categories but just chose not to identify themselves, or if they clearly just did not feel that they fell into any of these categories. So that may skew the numbers a little bit from that standpoint. When you also look from a demographic standpoint at gender, again, looking at practicing GIs and GI fellows, we see that from practicing GI standpoint, you've got about 85% are men compared to about 18% women. Looking at GI fellows, it's a little bit altered, still predominantly male, but you see that the number of women is growing compared to practicing GIs. And I think, again, when you look in the future, we're going to see more women in GI just based on the number of GI fellows who are currently training. When you talk about variables, I think a good portion of these numbers reflect the fact that there's a lot more women who are actually entering medical school now, and so that's why we're seeing these numbers the way that they are. So what's involved in GI training? A gastroenterologist must complete at least 3 years of internal medicine training in a program accredited by the Accreditation Council for Graduate Medical Education. And this is an organization that basically sets the standard for all medical training programs in the United States. So once you've done a 3-year medical residency program, usually it's sometime in the second year, usually the fall of the second year, that you start to think about things like applying for a fellowship program, interviews, and those kind of things. A typical GI program or a fellowship program is about 3 years. For the first and second years, the focus is generally on the inpatient consultative service, as well as developing procedure skills. There's an outpatient clinic to really try to hone in skills for outpatient management of GI disorders, which I think is a very different beast than inpatient medicine. There's core lectures and, of course, journal club. The third year mirrors the curriculum for the first and second years, but the difference is you generally have less time in the inpatient and consultative services and some of the other things, and more time reserved for research, clinical electives, and some advanced procedures. A fourth year in gastroenterology is optional and usually reserved for people who are have an interest in advanced endoscopy, research, or transplant hepatology. Up until about 1996, I believe it is, gastroenterology fellowship was actually 2 years, and it was at that point in time that it was determined that because of the growth that was seen in gastroenterology in terms of clinically and research, that a third year needed to be added. So it changed from a 2-year fellowship program. Most programs change from 2 years to 3 years. So what are the goals of GI fellowship training? To basically develop clinical competence in gastroenterology, including hepatology, clinical nutrition, and GI oncology, but also to gain technical endoscopic skills that allow diagnostic and therapeutic management of GI pathology. And I think when you talk to people who are in gastroenterology, quite a number of them will say that one of the things that attracted them to gastroenterology was the sort of unique ability to not only practice clinical medicine, but also do something diagnostically and therapeutically in terms of doing something with your hands and doing the procedures. It's a nice combination of two worlds. A lot of people who are interested in GI had an interest in either going into surgery or cardiology, which is another procedure-oriented subspecialty of internal medicine, or some of the other surgical subspecialties, and found that they liked GI because it not only incorporated some of those things, but there was another clinical aspect that kind of complemented that. As subspecialists, gastroenterologists have the expertise to evaluate and manage a wide array of gastrointestinal disorders and clinical problems. And I think Dr. Wyndham highlighted those actually very nicely. This kind of outlines some of the many things that gastroenterologists manage on a daily basis. Again, sort of speaking about some of the things that I think are interesting and unique about gastroenterology is, as you see, gastroenterology involves management of both, of several things: upper GI disorders, so esophagus, stomach, proximal small bowel disorders, colonic diseases, pancreatic disease, hepatobiliary, and so it's a combination of a lot of things. So it's a fair amount of variety, and there's never really a dull day or moment in gastroenterology. At a quick glance, there's about 2,500 or more than 2,500 GI fellowship applications yearly. As of June 2005, there were 157 accredited gastroenterology programs nationally. As of 2010, there were 420 first-year accredited positions, of which 90% of programs participated in the 2008 GI match, and that's actually increased incrementally over time. And as of December 2007, there were a total of 1,200 GI fellows nationally. So given all that information, what if you're an interested medical student? You've either encountered someone, a faculty member who was a gastroenterologist and you had interest, or you saw an interesting GI patient and you thought, I would love to do that as a career. What if you have interest in that? Well, it's never too early. Even as a medical student, that's actually the perfect time to start considering these types of things. What I would suggest as a third year, in your third year, you really want to do a clinical elective in gastroenterology. You want to ask lots of questions about the clinical practice of gastroenterology, both clinically, whether it's working in an academic environment, working in private practice, or doing research. You really want to ask a lot of different questions about things that may interest you. And it's the perfect time to have sort of one-on-one interaction with a faculty member who can provide that information. You want to follow your GI consult patients into the endoscopy suite. So let's say you have a patient who presents with melena, they're scheduled for an upper endoscopy, go see the endoscopy. See exactly what an endoscopy entails. See what the finding is, see how it's managed. As you saw from the video earlier, we very commonly see peptic ulcer disease, and managing that, it can be several-fold, one including sclerotherapy or applying endoscopic clips, and Dr. Wyndham showed that very nicely. So it's nice to have continuity of care with your patient when you've actually done a consult on the floor and you actually follow them into the endoscopy suite and then see them again on the floor for their post-endoscopy management. Get to know your program. Get to know the GI program that you're at. Get to know some of the faculty members at the program that you're at. Get to know what types of research are actually ongoing at the program you're at. I mean, this is a perfect opportunity to find out if there's someone at the institution you're at that actually has some interesting research that's going on about hepatobiliary disorders or colorectal cancer screening or something along those lines. It may strike some interest in you. Inquire about some research opportunities, or offer to write up a case report for an interesting clinical case that you actually saw on the consultative service. Lastly, consider attending a national GI meeting. Within the last couple of years, both the ASGE and the AGA have made it possible for medical students to actually attend some of our national meetings. And it's a perfect opportunity to actually see what GI looks like on the national scene. So there's several societies. The societies actually converge, and I'll talk about that a little bit more in a little bit. But they come together for a huge conference. There's lots of poster presentations. There's lots of learning sessions, some one-on-one didactics. So it's a great opportunity to kind of see gastroenterology on the outside looking in. For the interested medical resident, as an internal medical resident, continue to be actively engaged in clinical activities, electives, and research. Talk to the GI fellows at your institution. Find out, just ask them questions. So what made you interested in gastroenterology? What's good about it? What's bad about it? What can I do to make myself a more competitive applicant? Applications for GI are generally due in the fall of the second year residency. So again, it's nice if you kind of have some sense going into residency what you kind of want to do. It's absolutely not necessary, but it kind of puts you a little bit above the 8 ball when you're able to maybe get a paper or a little bit of research under your belt. Ask for letters of recommendations from a GI faculty member with whom you've worked, and you want to start early, so you don't want to necessarily go to someone who's never met you or had very limited contact with you. It's great if it's someone that you've either been on the consultative service with, or you've done some research with, or you've co-authored some type of case report or something along those lines. Both the ASGE and the AGA actually have a lot of support as well that they offer on their website. And here's a couple of websites that they actually give you some application tips and tell you about some career opportunities in gastroenterology. So a few words about the gastroenterology societies that we currently have. There's actually 5 societies, the AGA, ASGE, ACG, and the AASLD, which is predominantly Association for the Study of Liver Disease. The largest 2 are the AGA and the ASGE. A few words about the ASGE. It was founded in the 1940s, and it's dedicated to advancing patient care and digestive health by promoting excellence in gastrointestinal endoscopy. The ASGE has about 12,000 members worldwide, and the goal of the ASGE is to promote the highest standards for endoscopic training and practice and foster endoscopic research, as well as recognize distinguished contributions to endoscopy. And of course, it's the foremost resource for endoscopic education. The ASGE also offers a number of educational opportunities for different levels of training, medical students, residents, and fellows. Notable from out of this list of things is the First Year Fellows course, which is a course that's offered to first year fellows that actually gives them a one-day didactic on endoscopic procedures. There's a mentorship program that is actually in the process of being launched with the ASGE, which actually partners a GI fellow with a thought leader in gastroenterology. And of course, at DDW, Digestive Disease Week, which is our big conference every year, there is a diversity award that actually awards a $1,500 purse to anyone who actually has an abstract that highlights research related to either something diversity related as defined by either gender or cultural background. This just speaks a little bit about the ASGE First Year Fellows course. Again, it's dedicated to teaching first year fellows the basics of endoscopy. It's open to all first year fellows. There's a one-day full instructional lecture series that kind of talks about the basics of endoscopy, what is an endoscope, what is a colonoscope, these types of things. And then the following day is an endoscopic training module on pig models. The ASGE is a peer-reviewed, sponsors a peer-reviewed journal that comes out monthly and basically focuses on state-of-the-art endoscopy and new techniques. A few words about the AGA, the other larger organization in gastroenterology. It's dedicated to the mission of advancing science, practice, and advancement in gastroenterology. It was founded in the late 1900s and boasts about 17,000 members. It is the trusted voice of the GI community in addition to some of the other organizations within gastroenterology. Again, AGA, similar to ASGE, offers a number of educational tools for predominantly, I would say, GI fellows and faculty members or practicing gastroenterologists, but also tools for medical students and residents who are interested in a field in gastroenterology and are starting the process of interviewing and also applying to gastroenterology. The AGA also has two publications, Gastroenterology and Clinical Gastroenterology and Hepatology. Both of these publications actually are ways for original research, guidelines, and these types of things to be published by academic institutions to the GI community. And I mentioned a little bit earlier, there's something called DDW, Digestive Disease Week, which is held once a year in the spring, usually in May. And this is the one time where all 5 societies actually converge together. And it's a wonderful opportunity, again, for medical students and residents to come and kind of get a peek at GI before actually getting in, sort of to see what GI is all about, and even actually chat a little bit with some of the people who are within GI. And I would also add that it's an opportunity to see practicing gastroenterologists from different areas of gastroenterology, whether it's research or private practice or academia or industry. It's a good opportunity to kind of get a sense of whether or not there's something there that you would enjoy. Moving on, career development support, again, for medical students and residents. I've spoken about this. The ASGE and the AGA offer articles on career development topics. There's pre-training membership and conference attendance that is sponsored if the interest is there. And for GI fellows, of course, there's research awards that are offered for abstracts that are presented at DDW. We've got mentorship programs that are available and access to NIH loan repayment programs. Lastly, there's the Career Advisory Program, which is available not only to GI fellows but also junior faculty members. And this is chaired by Dr. Maria Cruz Correa. And this is essentially a way to confidentially email subject matter, send emails to subject matter subject matter experts to request career advice, and this is something that's confidential. The questions can range anywhere from contract negotiations to career choices, finding a mentor, balancing career and family, grant writing tips, information on the NIH loan repayment plan, and topics of concern for women and minorities. Lastly, I just want to introduce you to a few faces of minority leaders in gastroenterology. We've got Dr. Maria Brew, who is my co-partner with sponsoring this program, and she's actually professor-in-chief of GI at the University of Miami. Her clinical interest is inflammatory bowel disease, and she's written quite extensively about different aspects of inflammatory bowel disease. She is the current chair of the Underrepresented Minority Committee of the AGA, and has also been very active with the AGA Women's Committee. Dr. Patrick Okola, who's at Johns Hopkins, he is the chief of endoscopy there, and he has a clinical interest in interventional and innovative endoscopy and clinical epidemiology, and he's the immediate past chair of the diversity committee. Andrea Reed, she's currently a hepatologist at the VA. She, within the last year or so, moved down here from Boston, where she was assistant professor of medicine at Harvard Medical School, and she was GI Fellowship Program Director at Mass General. Her clinical interest, health disparities in liver transplantation and hepatitis C management and treatment. Her activities, past chair of the Underrepresented Minority Committee of the AGA, as well as the AGA Task Force on Underrepresented Minorities. Dr. Colleen Schmidt, she's a private practice physician down in Tennessee, very active with the ASGE. She's currently an ASGE board member, and she's past chair of the Health and Public Policy Committee and has past involvement with the Minority and Women's Issues Committee. Of course, there's Howard's own, Dr. Dwayne Smoot, who's a professor and chair of the Department of Medicine at Meharry Medical College currently. He's the immediate past chief of GI at Howard, and his clinical interest was in acid peptic diseases and gastric and colon carcinogenesis. I will note that, and it's really notable, he had uninterrupted NIH research support since 1991, which is a huge feat. He's currently very active with the AGA Underrepresented Minorities Committee. Then we have Dr. Robin Chutkin. She's assistant professor of medicine at Georgetown and medical director of the Digestive Disease Center for Women. Her clinical interest, digestive diseases in women, nutrition, and inflammatory bowel disease. And she's currently chair of the ASGE Public and Member Outreach Committee, as well as past chair of the ASGE Training Committee, and has been quite active in the AGA Women's Committee. And then lastly, Dr. Anil Rusky. He's chief of GI at the University of Pennsylvania. His clinical interest is high-risk GI cancer genetics and GI oncology. And as you can see here, he's vice president of the AGA Institute and previous chair of the AGA Institute and editorial board of the Gastroenterology, which is the publication that the AGA actually publishes. So in summary, gastroenterology is an exciting subspecialty of internal medicine that focuses on the management of gastrointestinal disorders. It combines clinical knowledge with technical skill. Currently, minorities comprise a small number of GIs nationwide, but clearly from the data I showed you in terms of demographics, of background, as well as gender, the tide is changing. Interested medical students and early residents are encouraged to seek out clinical elective and research opportunities, not only at your own institution where you're at, but even other places. Certainly a lot of medical institutions welcome having students come in and do electives. The ASGE and AGA have numerous resources to assist with the process of pursuing a career in medicine or in GI, and I certainly suggest that you look into those things. And in closing, I'd just like to say that, again, one of the important things for us in terms of promoting a program such as this was to introduce you to the field of gastroenterology fairly early in your medical career, because by the time you're a resident, most people are a little bit already differentiated in terms of what they want to do. So it's a good time to consider what you want to do. It's a great time to consider gastroenterology as a career. Again, if you have any interest, I would encourage you to talk to Dr. Sanderson, do an elective in gastroenterology, and obviously reach out to anyone in our organization. I'm available. We have lots of resources. So To that end, I'll invite any questions. Dr. Sanderson, if you'd like to make a few comments in closing.
Okay, so did anybody have any questions, any burning questions while we have Dr. Adams here? I know it was a long presentation, and I thank all of you for attending and for your attention during this program. We just want to stimulate your interest, to let you know that there's a great specialty out here, and to allow you to understand what resources are available to you. You know, you're going to go through many different rotations, and you're going to figure out what's right for you. But this is definitely something that I would suggest for those of you who, during the presentation or at some time during your training, have thought that GI might be right for you. I definitely wanted to also thank Naoma for helping us with this program. She is the chair of the Internal Medicine Interest Group from the medical school. She was instrumental in getting the word out for this program and very helpful with getting the kind of logistics done. I don't remember your name, but thank you. You're our angel to help us with the AV. Otherwise, we definitely would not have been able to bring you the program. GI is, it's a lot of fun. I don't know whether that came across. Today, I had conference at 8 o'clock in the morning. 9 o'clock, I had clinic. 12 o'clock, I did an ERCP. After that, we had a GI bleeder, which we banded. And after that, we rounded with our consult team. I'm a little tired, but I had a great day. And I think that's what you want at the end of the day. People always say, you hear it over and over, no matter what profession you go into, they say, you want to do something that you love, do something that you love. Well, in GI, I found something that I actually do love. So if I have to work and I have to do medicine, then this is what I want to do. So hopefully you'll find that for yourselves. So again, thank you, Dr. Adams, and everyone from the AGA. And with that, we'll close.